Thanks very much, Anthony. And first I'd like to recognise that we're standing on traditional Aboriginal land and pay my respects to the Gadigal people of the Eora Nation and acknowledge elders past, present and emerging. Look, I'm very pleased to speak at this first Ocular Melanoma Conference at Down Under. For those of you who've seen my t-shirt, I've sort of done this before, and certainly as a patient and also as a physician, I'm very keen to, I suppose, take some of that American experience as far as patient retreats and patient journeys here into Australia. It certainly helped me learn a lot about the condition, and certainly I'm somewhat jealous of the opportunities that happen in North America and Europe at a whole lot of their patient meetings. I'm a rural doctor. I've got a practice in Tamworth. I've practiced in a few different small rural towns, but children hitting high school, like a lot of my colleagues, has been a time when we've had to settle down in a larger centre. I've been active in medical politics for quite some time, heavily into the rural doctor movement, dabble in the AOMA, very involved in general practice training, on a number of boards in that regard, including my local health district board. My identity very much is as a doctor, and for those of you that are similar sort of generation to me, I'm sure that a lot of you recognise that within you. It's very much the way that we were brought up in medicine, that it sort of tends to consume a whole lot of your life. Certainly my transition, the transition from doctor to patient has been hard. It's hard for a whole lot of us. And many doctors have written on this, and I don't pretend to have any particular new knowledge or insights about that. But I suppose my journey would be an interesting reflection on what's happening. I have to go back to my initial symptoms, and it was the summer of 2012-13, and I must admit it was probably about the worst time of my life. I'd been in practice in town for about 10 years, and it was a really stressful time for me because my business partner and I were having a significant dispute with each other. And there was a whole lot of angst that hopefully didn't affect the patients, but it sort of was trying to tear the practice apart. For those of you that don't know Tamworth, can you imagine it's January, it's 45 degrees, and the country music's playing, and it was in the middle of the country music events in Tamworth, for which it's well known for. I was walking through a shopping mall and I thought to myself, gee, that clock looks really funny up there. And I thought, gee, it's really distorted. I don't quite understand why. So I got home and thought about it, and I pulled out an Amsler grid, and it's sort of the sort of thing you shouldn't do, and promptly diagnosed myself as having macular degeneration at the age of my early 50s. And of course, doctors should never diagnose themselves, so I went down to see my local general ophthalmologist, of which we have 3 in Tamworth. And, I had a nice conversation with the receptionist, who of course got me in quite quickly. And, I sat down and have lots of tests, and I know most of you also work in, those of you who are ophthalmologists also work in general as well as ocular oncology, and I'm sure you've got all those wonderful machines that you go through. So after about an hour or so, finally I face to face with the ophthalmologist, and he asked me if I've got any stress at the moment, because of course the distortion I was getting was due to the edema I had in my retina and my macula, and he promptly diagnosed me with central serous retinopathy, which of course is a stress-related disease, and I found out it was diagnosed during the Korean War, that sharpshooters were saying they couldn't see anymore. Their vision wasn't that accurate, and it It was a form of a stress-related condition. And, you know, there were studies at the time that sort of said, oh, these guys were malingering, but it was actually proven to be true. And I was told my retinopathy would go in about 3 months. So I dutifully turned up for testing, OCTs, every month. And when it didn't go in 6 months, you know, we've got a visiting retinal specialist who comes along and sees me, looks in my eye and goes, yeah, look, there's this fellow I want you to go and see in Sydney. Yeah, okay, I'm going to be in Sydney next week, so do you think I can see him then? Yeah, he said, yeah, sure, I'll send him all these photos down and you'll be able to get in to see him. Okay, so I suppose my first reflection or recommendation as a patient with a bit of medical knowledge is, and it's interesting, I like the New Zealand numbers there that said we get 8 new cases of ocular melanoma a year, which roughly works out to be 200 new cases in Australia in a year. And being a GP means I'm going to see one during my practicing career. A general ophthalmologist will see one every few years. A retinal specialist will see maybe 3 or 4 a year. Of course, you ocular oncologists will see many over the course of a year. We know that melanoma outcome is better the earlier treatment commences. Delay in diagnosis and treatment are very common in this. And I was reading last night, there was a study that showed that 37% of patients with a new ocular melanoma have had their eyes examined in the previous year without detection of the melanoma. And 71% of those that were examined had their eyes dilated. So I suppose my question is that you know, current screening isn't working, and how are we going to improve the detection of ocular melanoma in the general population? It's Ocular Melanoma Month now. It's May. There's all this stuff appearing in social media from those of us that have had ocular melanoma and those that are concerned with it and those that have relatives about having a dilated eye test. I suppose my concern is that as a screening tool, it's not been demonstrated to be that efficient. Maybe, I don't know, is it a question of better training, or is it a better, is there some special tools that are required to actually help diagnose melanoma when you see it if you don't happen to be an ocular oncologist? And certainly that story of mine with a significant delay in diagnosis was not atypical. So I'm down in Sydney that next week and I get a phone call. I'm doing what I'm doing in Sydney, and you know, I get a g'day. You know, my name's Michael Giblin. I've seen your pictures, and I just thought I'm going to see you tomorrow. I just wanted to let you know that you've got a little melanoma. Yeah, okay, fine. So we chatted a bit, and then look forward to seeing you tomorrow. And I'm sitting there thinking, ocular melanoma, okay. Go back to medical school and I start thinking, not ocular melanoma. Now that's the fellow with the glass eye and the nodular liver margin, and okay. That's sort of like the only training you get as far as ocular melanoma goes. And as a GP, I've never seen it in practice. So I'm now thinking, okay, so that's my story. My mind sort of went blank after that. Got myself together and went back to what I was doing. And what I was doing was actually I was selecting entrants to general practice training. So I was doing one-on-one interviews, interviewing about 30 doctors over the course of a day. So I suppose my second bit of advice as a patient is, and look, I love Michael, and I'm sorry he's not here. Maybe I'm glad he's not here, but look, each patient with cancer really only has one opportunity to hear that they've got cancer the first time. Please consider where your patient is and what they might be doing at the time, and ensure they've got some sort of supports around. And it was good. I did have lots of supports around. I had lots of colleagues, but I started to keep going with the interviews for that day because it's a national selection process. So I met Michael and did all the tests and got the diagnosis. And what was really interesting is, look, I've got a very small melanoma. I've got a very central one. as far as it was picked up very early because it's affecting my macula very close to the fovea. So we had a space of about 13 months, I think, before we actually made a decision and proved that it was actually growing. And over that time I discovered there was absolutely no ruthenium plaques available in New South Wales, which was, I thought, an interesting choice. And you know, the discussions we had, I mean, I was offered a whole variety of treatments. We went through ruthenium, iodide, laser. We talked about stereotactic as well. I went and had a meeting with my local MP, got a very nice letter from the Health Minister, and I actually did know her personally, and was told that iodine plaque is good enough, and that's what the eye hospital had. So I got shuffled off down to see John down at the Eye and Ear, and I've had 6 monthly follow-ups since in Sydney, and it certainly hasn't been a problem. The surgery itself, I mean, no one, well, a few people here have had plaque surgery maybe, or they will have tomorrow anyway. It's an interesting experience. I find it interesting that in the US it seems that you go home with your plaque and a lead eye patch. Here, of course, we stay in, which is, I think it's nice, I think it's supportive, and I understand that, you know, we've got very different health systems. And I think it's good. I got very well cared for. So now I guess I'm the GP with cancer, and I'm a GP with a very rare cancer, and I suppose that's my new identity. And I've always been quite active in social media, and there's a whole lot of social media groups out there, particularly on Facebook, around ocular melanoma. I think they are really, really helpful groups. There's a whole lot of people that have gone through the journey who are quite experienced. There are some health professionals on there who've had ocular melanoma, and sometimes we're able to assist with some of their questions without sort of trying to undermine the professionals that are treating them. Certainly I try not to provide direct advice, but the advice I provide tends to be fairly general. I've had the opportunity to actually travel to the US to patient meetings 3 times. I've got quite a lot out of it, especially hearing some of the technical advances. I still remember my very first one. Someone came over and tapped me on the shoulder and said we needed to talk, and I thought, you know, I didn't quite follow this. I mean, I'm always the only Australian there, and the bizarre thing was we actually had the same surname. Now, Kamerman is not the most common name in the world, and not only did this fellow have the same cancer, to top it off, he's actually a doctor as well. So we've had the total of 3 conferences together, caught up with David socially. Unfortunately, he actually passed away last year from his tumour, and I must admit, you know, that was a very hard time for me finding out about that. He and his wife were major fundraisers for the Ocular Melanoma Foundation, and in the course of his fundraising, actually funded 2 research students over there, totally from his fundraising. The problem with social media for the Australian ocular melanoma population is the bulk of the discussion comes from America. The discussions are often, people are very passionate about their treatment choices, and that always happens in social media because they're very invested in the choices and the decisions they've made. And the other problem with it being in America is America will offer the very best medicine that you can possibly afford. And so therefore everything is offered to them. And I mean, as a health professional in a first world country, I see a whole lot of over-servicing going on as well. And particularly in areas where there really doesn't seem to be a whole lot of proven benefit. it's said that 50% of people will die from this disease that have it, and everyone wants to be in the other 50%. If you're going to get metastases, you want them found as soon as possible. These social media groups are, and I'm talking about the patient-led perspective, they're not groups where you can have a serious discussion on issues such as lead time bias. But certainly there does seem, and we've heard today about a whole lot of new advances in the treatments of metastases that seem to make surveillance worthwhile. And I think this is what we're getting, some of the points we're getting to today. The third thing I'd ask for is that, we are a small country. There are 1, 2, 3, sometimes 4 ocular oncologists in each state. There are fewer medical oncologists that specialise in ocular melanoma. What we, as a patient population, are looking for is a very clear and concise national guideline as far as screening and surveillance for metastases, because all of us have been through it, and this is the one thing that we're all looking for. So that would be my final request to the experts here, because it's often the thing that's burning all of our minds. Thanks.
It's John McKenzie here. I better chat to you.
About my eye, it's just a bit...
We'll consult later. I was recently at the International Society of Ocular Oncology meeting in Los Angeles, and they had a patient group that was outside the forum. They had a stall at the thing, and they had people there to answer questions. They also had people like this meeting coming into the meeting, and at first I didn't realise that there were patients and things going on, and I was a little bit not taken aback, but I think that to me, one of the things that it does is it alters some of the discussion that people have, and I think that one of the things that we've got to be very careful of is making sure that that it doesn't inhibit open discussion amongst the medical profession, because I think that one of the things is that we have to be brutally honest about what our research is and where things go wrong. And I think that that's one of the things that was brought up by the patient. Patient actually asked a question, and she was a parent of retinoblastoma patient who had unilateral disease and died. And they're really quite vocal about this because it's probably something that shouldn't have happened. But I asked the group what they saw as their role, and the woman on the desk said that she thought her role was to make sure that patients with melanoma got appropriate care and they got support to get that care, because I think particularly in the US people do travel quite a lot to get their care, and that's one of the things that we see less of, albeit you came to Melbourne for a particular treatment. What's your view on what role a patient support group should be doing, if you have a view?
I think if you believe in patient-centred practice, I think they're really at the centre of that sort of discussion. Should patients be involved in meetings such as this? And I know there are a few of us here, and I think all of us were actually invited to attend today. People want information. People, the groups I'm involved with, non-health professionals will have read a whole lot of the journal articles and look at results and keep an eye on things. They're very aware that they're dealing with a disease that is often fatal and is extremely rare. So they're wanting to hear these sort of discussions. They want to hear the bad outcomes and they want to hear the good outcomes as well. And I personally, I don't think there's anything that would be discussed at a meeting that patients would find that should stop clinicians being honest. I think the role is, though, that people have to identify themselves with who they are and where they're coming from, if they're asking questions and participating. And also, you need to have support people around just in case. Sometimes all this stuff is very emotional, especially, you know, when people start talking about their own stories.
I also, like Ian, is on some of those social media groups, and I sort of lurk there. Maybe I shouldn't, but I think the role, they sort of energise, and I think me personally, in terms of understanding the suffering and trying to help where I can. There have been certain instances on that forum, for example, where patients quite honestly have been told erroneous facts, like, you know, after 2 years your ocular melanoma is not going to come back. So the average time of metastasis is 2.5 years. So I don't know who told this patient that the melanoma is not going to come back after 2 years, but someone said, is my melanoma not going to come back? Can I go back and not have any scans? So you have to say, well, you know, actually, I don't think that's a good idea, that you stop doing surveillance scans for a high-risk melanoma after 2 years. And then, so that's the first thing, is to sort of establish standards of care, because it is, unfortunately, in a large country, diffuse. The second thing is that it's the patient perspective. Certainly, if we're putting a Cancer Australia grant in as a big collaborative group, 30% of the grant is on consumer input. So if we, you know, do a survey of the consumers who have ocular melanoma, and they identify that establishing a national guideline is something that we should put resources into, then that's something which is very much picked up by granting agencies, that we can show that we're working with consumers to help standardise care across the country, and there certainly still are gaps. Jess, you wanted to say something?
As a patient advocate as well, I think it is incredibly important. I felt incredibly alone at times through my treatment. You know, I'm also a young cancer survivor, so I was alone on both sides of that. But I would never undermine the professionalism of a doctor. I don't think that that's my role on, you know, any of the social media sides. But it is there to give support, to give understanding, to make you feel like there's a community. And to be able to communicate that and to give another perspective is really valuable. And it also grounds you from, you know, medical jargon and things that are going over your head, and just allows you to come back down to the system and to realise that you're not the only one. So I think that's why it's so important.
Great. Bertel, you want to say something?
Hello. We've met before. I don't know which country.
It was the US.
Yes. It's interesting to hear that you read all the journals about ocular melanoma. One of the problems with articles published in journals is that they are published by experts who treat thousands of patients in centers of excellence, whereas many patients with ocular melanoma are treated in smaller cities by surgeons who have less experience, fewer facilities, and so on. And so I think a lot of patients have unrealistic expectations. It's not their fault. It's just the papers that they've read that have come from those few centers of excellence. So I've been speaking to people at CureOM and Cure Insight and so on about patient registries, and my suggestion has been to try and measure real world experience, not in the centers of excellence, but around other cities, so that when they get counseled about the prognosis, about the chances of success, the chances of keeping vision and so on, they will have a better idea of what might lie ahead of them. So this is one of the problems that's happening, that a lot of patients, at least in Britain, are becoming antagonistic against the ocular oncologists that are looking after them and the services, because on the internet they have certain expectations built up, and then the doctors just can't reach those levels. So I think what I'm going to be saying in my talk tomorrow to conclude is that empathy works both ways.
Great. Okay, so thank you, Ian.